Welcome to Dental XP. My name is Dr. Tal, T-A-L. Last name is Moore, M-O-R-R. I'm from Aventura, Florida, and I'm a prosthodontist. I have a private practice limited to prosthodontics. The topic of today is going to be soft tissue manipulation in implant aesthetics. We're going to talk a little bit about how to determine if it's a good site or not for implant placement, and how we manipulate the soft tissue to achieve the desired aesthetic result that we want. When you think of implants and what determines the aesthetic success of implants in the anterior region, it's basically the soft tissue. It has nothing to do with the final tooth form or contour to a certain degree, or the ceramics, but it has to do with the soft tissue contour. And if you look at this case, which was finished with veneers and one implant crown, it would be hard to determine which tooth is the implant unless you looked at it for a while, and after a while you'd figure out that it's the upper left canine. Now, why is this case fairly predictable situation for us to be able to replicate nature? Well, if you look, this is how this patient came in. After a full round of orthodontics due to some occlusal issues, you can see that on the upper left canine we found internal resorption following the orthodontics, and this necessitated extraction of this tooth. So why is this a predictable situation for an aesthetic result using an immediate implant? Well, you'll notice that if you look at the soft tissue, the canine is actually in a perfect position relative to the soft tissue levels. Now, if you look at the adjacent teeth, you can see that they too are in perfect position. And we know that if we extract the tooth, we're going to get some resorption of the bone and the soft tissue. So why is this a good situation? Well, we know that the facial plate is intact. It's greater than 2 millimeters in width. How do we know that? By sounding to bone. We also know that we can graft the facial margin or change the biotype for this patient, thickening the tissue and rebuilding the facial aspect. It's mostly the interproximal aspect that is determined by the bone. We can rebuild the facial aspect to a certain degree as long as we have a facial plate. We also know that the interproximal bone needs to be a minimum of 1.5 millimeters, and in this case we have plenty of bone on either side of that canine, which is thick and will withstand the forces over time. And we know that the bony peaks are level and flat on either side. This is an ideal situation. The pointier the peaks are, the more chance for resorption. These happen to be very wide and flat, and we don't expect to have many changes. And it's the bone on the adjacent teeth to the site that are critical here in terms of supporting the soft tissue when we're done. And finally, the tissue scallop is flat. What does that mean? Even though this patient has thin tissue, you can see that the papillae are not very pointy. That's actually an advantage. We're going to be doing prosthetics anyways on the other teeth to close those spaces, and so we don't expect to get a lot of recession of the soft tissue. So the tooth was extracted, an implant was placed. This happens to be a camlog, but it doesn't matter what type of implant is put in this area. It's an ideal situation. The tissue is grafted at the same time. This is a peak healing abutment, which was trimmed by the oral surgeon to maintain the soft tissue. We then take another peak abutment, screw it in, and you'll see that the first step I'm doing in trying to manipulate the soft tissue is to prep the abutment initially to the correct contour. Now you notice on the upper left side that the soft tissue is more coronal than we want it to be. So the objective here is not to cut away soft tissue, but to mold it by adding contour. This is the art concept in which you add some acrylic or composite to your peak abutment on the facial aspect. How much is defined by how far you want the tissue to rise. The more you add material, the higher the soft tissue will go. So you can see here, after that is added, you can see the provisional once the tissue is leveled with the central incisor, and after a while you can see that the soft tissue molds very nicely, and in fact it even came down a little bit more coronal than we anticipated. So by adding a little more bulk, you can get the final restoration, which is predictable in terms of soft tissue form and contour. And radiographically you can see that that implant is in the upper left canine area. How about this situation? This patient had this bridge for 25 years. She's very unhappy with the way it looks. She has recession on tooth number 8, which is long. That's one thing that bothers her. And the second thing is that if she's going to redo it, she'd like to have single teeth. So the question is, can you do this predictably? Well, what do we know? We know that the papilla height between an implant and a tooth is going to be generated about 4 to 4.5 millimeters. This was told to us by Salama and Garber, and as well as John Coyce, and as well by Joseph Kahn. And basically, in this situation, we know that we're going to lose some of the papilla. We know that the papilla height between teeth is different. It's 5 millimeters. Okay, that's what we expect to regenerate. So we know we're going to lose some tissue. So the question is, why is this a predictable situation for an aesthetic result using delayed implant placement? Well, one is that the papilla is more coronal on the side of the implant, on the distal aspect of tooth number 9, than it is on the contralateral side. So if we do get a little bit of recession, that's okay. We notice that the bony peaks are level on either side of the missing tooth. That is an ideal situation, because those are the peaks that are maintaining the papilla on either side of that implant. We have a very wide implant site, and we can alter the biotype by doing some sort of grafting procedure in this area. So it's actually an ideal situation. So after grafting the facial aspect of tooth number 8 by re-preparing the tooth, bringing the margin more coronally, and then placing an implant in that area, we're able to get a more aesthetic and predictable situation. And we manipulate the tissue in the same exact way as before, using a different system, different type of temporary abutments, but the same concept. You add material to the facial aspect to alter the facial. The proximal is going to be determined by your bone. It's the facial aspect that we're going to mold and give the illusion of a scallop by altering the facial aspect. So this is once I've put in the temporary abutment, I've relined my provisional, and now I'm going to be waiting till it heals. You can see how there's tissue blanching, and a week later you can see that the papilla are beginning to come down. Now, this is how the patient came in, and this is how we finished. And unfortunately, the patient wanted toilet bowl white teeth, but all in all, I think the contour of the soft tissue on the upper right lateral incisor came out fairly well, considering that this is 2 days after placement of that implant because the patient had to leave. So again, a predictable situation by virtue of looking at the bony contour. Another situation, which is a little bit more complicated, this patient came in, she had this bridge for about 20 years, there's lack of proportion of the teeth and symmetry, and the patient really wasn't happy with the way it was looking these days. If you look introrally, you can see she's had periodontal disease, she's had pocket reduction on those teeth to try to eliminate the periodontal problem. So the teeth are going to be long no matter what. So this patient came in and she was unhappy with the way her teeth looked. They were disproportionate in size. She didn't like the way the color was or the fact that she had very long teeth. And if you look introrally, you can see why she's unhappy. She's had some recession along with some periodontal surgery to try to eliminate the bony defects. Unfortunately, she still has some failing teeth due to some hemiseptal defects on the posterior teeth. So the first thing we do in these types of cases is provisionalize the patient, try to mold the soft tissue, and the way we were able to eliminate the periodontal disease in this patient was by extracting some teeth. The plan was to extract the periodontally infected teeth, place some implants, and then restore them. This is the restoration. You can see the implants were placed strategically to eliminate the periodontal disease. There was no need to do any further surgery on this patient. And after the implants were placed, we're now left with this situation. The provisionals are in the correct position, but the soft tissue is not. So now the objective is to mold that soft tissue and get it to the correct position. So the first thing we do is put our temporary abutments in, prep them a little bit so they draw, and now refine the soft tissue height by adding or subtracting from the bulk of that temporary abutment. So again, we go through this process, adding composite to that temporary abutment, and After placing it in the mouth, we then prepare it in the mouth with the soft tissue in the ideal position, and now we're able to put the soft tissue margin at the same level as our temporary abutment so that our cement line is more coronal relative to the head of the implant. This is what the temporary abutment looks like after preparation. You can see that just adding a little bit of composite really has changed the facial aspect of that canine. On the other side, if you have solid abutments, you can do this by relining in the mouth, then getting the analog and another final abutment of the same shape, and then adding acrylic cervically to close that area and shape the emergence profile of that temporary. So this is after some healing. You can see on the left-hand side the soft tissue around the canine is a little inflamed, while on the right it's healed for about a week. We've now made the soft tissue levels of the canines the same on either side, and now we're going to take an impression of the temporary, make a matrix so that we have predictable way of restoring these teeth just like the provisionals. And in this case we decided to use all zirconia restorations, including a zirconia bridge on implants. You can see that the abutments were actually porcelain fused to metal abutments, so that if the patient did end up getting some recession, you would not see any metal exposure. So this is what the upper arch looks like after placement. You can see a little bit of irritation on the soft tissue due to cleaning of the cement with a brush. It has nothing to do with inflammation. On the lower arch, we again restored the whole case with zirconia, and this is what the patient looked like when we were finished. The real key is what it looks like intraorally, where you can see that it's very hard to determine which tooth is the implant and which tooth is the crown. So we were able to level the soft tissue by manipulating the facial aspect via that arc concept described by Phillips and Coyce. This is the final result, and you can see again the periodontal disease was eliminated completely by virtue of extraction of the hopeless teeth. The last thing I'm going to talk about are posterior implants, and you can see that this patient came in, she fractured off her bridge, and now you have to make a decision. Do you crown lengthen these teeth to maintain them, or do you extract them and place some implants? The way you determine that is by looking at the radiograph, and you can imagine that if you do crown lengthening on these teeth, there would be nothing left. So this really wasn't an option, and we decided to place implants next to each other. So what's the minimal distance you need between two adjacent implants to try to maintain the bone and therefore the papilla? The literature tells us that it's somewhere around 3 to 3.5 millimeters. Well, so we go ahead and we place our temporary abutments just as described before by adding the contour labially to try to create the illusion of a scallop. And actually, considering that there's 3 implants close to each other, this is a very good result. You can see the final abutments, again, porcelain fused to metal abutments, and the final restorations on the 2 bicuspids and the molar. Considering that these implants are close together, this is about as much as you're going to get, because the maximum height of the papilla between 2 implants from the bone is somewhere average 3 to 3.4 millimeters. The range is 1 to 7, but you're not going to get the same as you have between a tooth and an implant. And if you draw a line and you see the relationship of the canine to the bicuspid, which is a tooth to implant relationship, you can see how more coronal that papilla is as compared to the papilla between the implants themselves. So in terms of what we were able to achieve in tissue height, this is about as good as you're going to get. And radiographically, you can see that why this is occurring, and that is that there's a bony scallop around teeth. That peak of bone on the proximal side is maintaining the papilla more coronally. As soon as you extract teeth and put 2 implants next to each other, because they're flat, the bone will die back. That peak of bone will not maintain itself very long, and that's why you have the soft tissue contour that you do between implants. So with that, I'd like to thank you very much, and have a nice day.